Sorry for interruptions. So just to start again, the editaceid antrum, that is posterior part of the middle ear cavity, and this editaceous is an opening through which the atic communicates with the antrum, and it has four walls: the roof, which is posterior extension of the tegmen tympani, and it separates the middle ear cavity from the editus. Sorry, it separates the middle cranial fossa from the editus, and medially the medial wall is related with the horizontal semicircular canals. Laterally, the fossa inguinus is related, and below, the facial nerve curves courses just below the editus. Now, the mastoid antrum. Posteriorly, this is the large ear containing a space which is situated in the upper part of the mastoid and is bounded by again the roots, that is tegmen and which is a posterior extension of the roof of the editus, and it separates middle cranial fossa from the mastoid antrum. The lateral wall, which is formed by the squamous temporal bone, which is about 1.5 centimeter in thickness, and on lateral surface, the MacEwen triangles, that is landmark for the mastoid antrum. So we'll discuss later on about the MacEwen triangle and the medial wall, which is formed by petrous bone and related to posterior semicircular canal, endolymphatic sac, and dura of the posterior cranial fossa. Anteriorly, it communicates with the atic through the editus. Atic is a part of upper part of the middle ear cavity, and medial to lateral relations are fluents. The anterior wall of the antrum is actually the posterior wall of the middle ear cavity. So from above to below, the relations are facial nerve canals, editaceid antrum, and facial recess. Deep bony external aortic canal is important part, and in case of mastoid abscess, this part is broken and diagnosed as sagging of the wall, posterior wall, in the deep part of the bony meatus. So this is the important sign. Now the posterior wall, which is related with sigmoid sinus posteriorly and separated only by thin plate, that is sinus plate. The floor is mastoid tip and also related with the jugular bulb, medial to facial canal, digastric ridge, origin of sternocleidomastoid takes place over the tip of the mastoid, origin of posterior belly of digastric through the digastric ridge. These are important landmarks we discuss later on. In this picture, we can see the different relations of mastoid antrum. The superior relations is middle cranial fossa, already discussed, and rarely related with the middle ear, external aortic meatus, facial nerves, and post-oral skin. So, floor is related with jugular bulb, digastric muscles, sternomastoid muscles, and posterior wall. Posterior wall has sigmoid sinus. Similarly, medial wall related with the posterior cranial fossa and posterior semicircular canal. Now, this MacEwen triangle is important landmarks over the lateral wall of the mastoid antrum, and this is triangular bounded above by the temporal lines. Now, this is temporal line, and the second line is just above the external aortic canals, posterior to the posterior part of the external posterior superior. You can say it posterior superior part of the external aortic canals, and third is a tangent that is drawn from temporal line to mid part of the posterior superior external aortic canals. So this is important landmarks. Here is present just you can say it anterior lines or posterior superior wall. A spine is there that is called suprameatal spine. Suprameatal spine. You can feel very easily from now. And the mastoid antrum is just 1.5 centimeter below these landmarks. So this is important landmarks. Now about the mastoid air cells. Mastoid antrum is also a air cells, but it is single, large, and constant air cells. And below the mastoid, there is comb-like structure. Sorry, there is a honeycomb-like structures. In the mastoid is known as they are known as mastoid air cells, and they are actually of three types. The cellular means well pneumatized, and in 80% cases, this type of mastoid air cell scenes. The diploic here some are cellular and some part is bone marrow. So it is diploic. And acellular, no cells, no bone marrow, complete rotation. So only 20% are seen acellular and diploic. In acellular or sclerotic mastoid, the sigmoid sinus is sometimes entirely imposed or positioned. So there is difficulties during mastoid exploration, during mastoid surgery. Now, depending on location of mastoid hair cells, we can divide in different parts. Means mastoid hair cells are of different types according to their sites. For example, at the root of the zygoma, the cells are known as zygomatic hair cells. Similarly, if they are present in tegmen cells, they are known as tegmen cells. Perisinus cells means overlying over the sinus plate, sigmoid sinus plate. Retrofacial cells that are present around the facial nerves. Perilabyrinthine cells are present into the labyrinth above, below, and posterior part of the labyrinth. Peritubal cells around the Eustachian tube, and tip cells which are present into the tip of the mastoid. Marginal cells, uh, again cells over the sinus plate, behind the sinus plate, and squamous cells that which are present in the squamous part of the temporal bones. Now the blood supply, arterial supply of the middle ear cleft is done by both external carotid and internal carotid. The branches of external carotid, like medullary artery, in form of anterior tympanic artery, middle meningeal artery, artery to pterygoid canals, and stylomastoid artery, that is branches of posterior auricular artery, which is branches of external carotid. Similarly, the tympanic branch of the ascending pharyngeal artery, finally the branch of external carotid. This and internal carotid artery in form of corticotympanic branch supply the petrous part of the middle ear, petrous part or middle ear cavity. The venous drainage done by pterygoid, venous plexus, superior petrosal sinus, the sigmoid sinus, and the lymphatic drainage. The middle ear is drained to retropharyngeal and parotid nodes, and the Eustachian tube to retropharyngeal group of nodes. Means actually they are drained to retropharyngeal group of nodes. Now, the one important structure of the cleft, middle ear cleft, is the Eustachian tube, which connect the nasopharynx with the tympanic cavity. The total length in adult is 36 mm, and the direction is downward, forward, and medially from its tympanic end, forming angle of 45 degree with the horizontals, and enters nasopharynx 1.25 centimeter behind the posterior end of the inferior turbinates at the lateral wall of the in form of slit. The tympanic end is oval, about 5 into 2 mm area. The area is 5 mm into 2 mm, but the pharyngeal end is slit-like. Just see, this is slit-like. This is a pharyngeal end, which is slit-like in the resting position. Now this tube is divided in bony and the cartilaginous part. The bony part is one third, that is about 12 mm, and the cartilaginous part is about 24 mm. At the junction of both, lightning here. At the junction of both the part, the tube is nervous and is known as isthmus. It is known as isthmus. Now the anatomy of cartilaginous part. This cartilaginous part is made up of single piece, which is folded upon itself to form the medial wall, roof, and partially the lateral wall of the tube. This is the medial wall. This is the medial wall. Then the roof, and finally the lateral lamina, that is partially it is covered, and the rest part of the lateral wall is formed by the membrane, fibrous membrane. Just see the fibrous membrane. So laterally this cartilaginous part is absent. At the junction of the lateral lamina and the medial lamina, the cartilage has abundant amount of elastin, that is called elastin hinge. Now that muscle tensor tympani, tensor palatini, which is attached with its posterior fibers to the lateral lamina, and this is the main dilator of the Eustachian tube. This is the main dilator of the Eustachian tube. The second muscle, that is levator palatini, which is attached with the floor and the medial lamina, perhaps helps the lateral tensor palatini. Now the ostomen pad of fat, that is along the lateral lamina, lateral membranous lamina, the bulky character of this fat pad helps to close the Eustachian tube. It helps to close the Eustachian tube. The next part is difference in adult and infant. Infant Eustachian tube. It is asked in examination very frequently. So first is the length. The adult Eustachian tube is 36 mm, while the infant is 18 mm. You know, the bony part in case of adult is one third, but in infant this bony part is slightly longer than the cartilaginous part, slightly longer than the cartilaginous part. The angle with horizontal is 45 degree in adult, while 10 degree in infant. Now the lumen, which is narrow in adult, so or wide in infant, the isthmus is present in adult and is absent in infant. So the infant Eustachian tube is wide, short, and horizontals. Next, about the cartilage, which is rigid in adult, in infant it is flaccid. The elastic recoil is effective in adult, while it is ineffective in infant due to few or lack of elastin fiber. In infant, the elastin is either very least or absent. So this is ineffective. Now the osman fat is more. Similarly, infant it is less. Thank you. यहीं पर आकर डाला जाए ठीक रहेगा. हाँ बैठे बैठे
Kindly give your attendance, please.
Sir,
any question? Any question?
No, sir, all clear.
यहाँ ये ऊपर से जाएंगे ना सर, तो सब अपने वो दिखा रहा है, अटेंडेंस सबका रहेगा. 15 हो गया. टोटल